All right.
Okay.
This is Dr. Lauren Fine interviewing Dr. Cedric Spock. Hello, Dr. Spock.
Good evening.
Tell us a little bit about who you are.
I am a clinical infectious disease specialist at Baylor University Medical Center, and I'm also a trained clinical virologist,
So handy to be in these times.
unfortunately.
All right. So we have a couple of burning questions. I'm one of the emergency physicians at Baylor University Medical Center as well. And we just wanted to review some clinical questions that have been coming up frequently on our shift, or shifts, many, I should say. The first question up is, what do you think is the best PPE to wear for when providers are collecting NP swabs on possible COVID patients?
Wow, that is a difficult question for so many reasons. So the main issue we got to it's a great question, but the main thing we have to consider is remember that this virus has really only been characterized for 4 months. And so we're trying to figure out the best way to move forward. And so that's why a lot of the recommendations keep changing so quickly. As far as collection methods for what we're referring to as a nasopharyngeal swab, I know that you and I talked about this over the last few days in a variety of media, and that apparently in South Korea, they do have a training video that they show the patient on how to self-collect the nasopharyngeal specimen. And I haven't had a chance. I was actually going to go look for it, but I don't speak Korean. And I thought it would be interesting to find it. As far as healthcare workers are concerned, the initial response was to treat the virus like Ebola. And since they were going to treat it like Ebola, the PPE that was recommended was basically sort of maximal protection, gloves, gown, face mask, PAPR, etc. Now they're starting to say that we don't need those kinds of methods, and that droplet, or alternatively referring it to sort of like as an enhanced droplet precaution. So many of the medical centers across the country are doing gown, gloves, face shield, and mask.
What do you think is best? Do you think N95 versus surgical mask makes a difference here, assuming that we're kind of away from PAPRs in this setting?
So I'm going to answer these questions ignoring all the problems of supply, because I think when different experts start talking about questions of this nature, they're balancing the challenges of supply. And I'm going to be a positive thinker and assume that the supply will fix itself over the next few weeks. Recognizing that this virus does have an ability like influenza to be able to live on what we refer to as fomites. The fomite would be any foreign surface. We got to realize that any foreign surface could potentially lead to an infection if the person at risk took that, had it on their finger, and then rubbed their finger on their mouth, nose, or eyes. So it would make sense to me to protect mouth, nose, and eyes, and also to protect mouth and chest, because you don't want to get anything there. So a gown would make sense, gloves would make sense, and then a face mask would make sense. I don't know if we have enough science to tell the difference between a regular surgical face mask and an N95. I do know that they just published unpeer-reviewed data from Wuhan, where they pointed out that all the nurses and doctors at the hospitals in Wuhan, where they had large number of cases, that if they wore gloves and N95, the reported percentage of infections in those healthcare workers was 0. I do not know how they defined infection. I do not know if the healthcare workers had additional personal protective equipment.
All right. I have to say, since we spoke last, I also looked up this question about having patients collect their own specimens, and I did find a study in influenza, small number of people, I think 72 controls and 72 cases, and they actually found that self-collection was about as effective, and it was actually preferred by a slight majority of the patients. I don't know if there's been studies for COVID self-collection yet, but do you think it's reasonable to assume that they could probably perform it just about as well? It was in this study they gave patients a written template, but I think with a video and kind of proctoring by a professional, it seems like a pretty reasonable way to further distance our providers from the face of the patient.
I think it's a very good common sense. I also can't think of any, I'm trying to think of all the different regulations that come with patient specimen selection. Like, if you think about, like, obtaining a urinalysis or even a stool sample, and there is, with those things, a sort of the patient themselves has to be able to provide you the urine or the stool sample. So I think this is a great question, and maybe a way to frame the question is, could we somehow protocolize it and maybe even document it and maybe even publish it? Because, like, if you could actually make a video, have the video be available, and then use it, and then do a study, and you could even do a pilot, that would be interesting. And that would be maybe a better way to recommend it to be done, as opposed to just, oh, we're two doctors, we're talking, we think this makes sense. I think in order to get buy-in, we need to take advantage of the lack of data and generate the data.
Yes, I like that. Let's do that in our free time.
Right, and then that would be a way then to appeal to the system, the hospital, et cetera, like, listen, we don't know the answer. Let's try this. Let's try a video. Let's have somebody show a mannequin and then show a human do a self-selected or self-collected nasopharyngeal swab, and then let's show the data.
I love that idea. When we have free time, I would definitely like to pursue that. So to recap, you think that we don't really know exactly what to wear, but some non-peer-reviewed stuff out of Wuhan suggests if you wear extended droplet contact plus an N95, then no one got sick, but we might be okay with just extended droplet and contact, which I want to kind of re-ask a similar question to before, kind of a slightly different group of people. You know, we actually have an advanced practice provider sitting in a tent or standing in a tent in front of the ER screening all of our kind of respiratory tract people. And although none of the people who are going into that tent are technically undergoing any aerosolizing procedures, there's no BiPAP, CPR, intubation in the tent, a lot of the providers are very apprehensive to be in there without an N95 on. What do you think? Do you think they need an N95? Do you think they'd be fine in a surgical mask, plus, the other stuff we've discussed?
So, well, we have two issues to the question. We have a scientific question, and we have an emotional question. And the apprehension is certainly real. And in the midst of this crisis, which is now a word that we've overused so much that it's lost all of its value, I think when the emotional aspect comes into play, it is difficult to just say, hey, don't worry about this. We are certain that what we're telling you is correct. Oh, tomorrow we're actually telling you something different. And I think that's part of the apprehension, is that the recommendations and the suggestions continue to change. So when we look at our own healthcare providers, I think it's kind of the same as when I take care of my patients. Like, I take care of my patients, and I take care of them, and I try and provide them the best I can. And I don't typically consider the economic issues of, how many vials of penicillin do I have in the hospital? Or how many CT scans am I allowed to order? I think clinically, and I'm like, I'm going to do this for my patient. So if you have somebody going into a tent to test somebody, how do you convince them that it's safe? Because when you try and tell them the science, then they really ask you objective questions, and you have to recognize the science is uncertain. And that's the big challenge. Like every time I get asked every day, it's like, and then when I listen to these interviews of all these really smart people like Dr. Fauci on the JAMA Network YouTube channel, and he admits himself, we don't know all these answers yet.
All right, so we don't know. There's a big emotional component, and right now, certainly, while we have N95s, we're going to continue using them because they certainly make us feel better, and they're maybe more effective. Maybe, we don't know.
And because then the question is, well, are the N95s less effective? Do they put the individual healthcare worker at greater risk? Like if you wear it for an extended period of time, is there like a moisture buildup? Is there a grease buildup on your face? Do you acquire virus on the exterior surface on the straps? Does that put you at risk? We don't know any of that.
Yeah.
And so I try and equate it to a completely different virus. It's a similar kind of conversation. 30 years ago or actually now 40 years ago when we were really understanding herpes simplex, specifically genital herpes, many, many people were convinced that they could acquire genital herpes if they sat on a toilet lid. And people refused to sit on toilet lids at public restrooms because they thought they were going to get herpes. And then when HIV first came around, there was another great concern that if they just go to a public restroom and just go do their business, whatever it is, that they're at risk of acquiring either herpes or HIV or both. It's never been shown, never been proven. In fact, it's completely wrong. So we may learn more about this virus over the next 6, 12 months, where we'll be like, oh, actually, an N95 is completely not helpful. And then some wonder, God, could an N95 be harmful because it does increase the ambient temperature around the nose and the mouth while you're wearing it?
Oh, good. This is really helping me solve some burning questions that I have. This conversation. All right. We are told that wearing a mask as a provider helps us mitigate our risk of acquiring COVID, but it is not recommended that the public wear masks. I have my own sense of why this is. Would you share your insight as a infectious disease specialist?
Well, when they provide recommendations on the public health level, it's always a balance between the risk and the benefit. And then as the conversation of the risk changes based on the prevalence of a disease, then the recommendations may change. Another example, if we go back to completely different infectious disease, look at the history of condoms. 40 years ago, HIV was around. It was very controversial to recommend condom use. There were people who would get opinionated based on religious views. Alternatively, they'd say, you know what, it's a barrier method. It's going to increase risky behavior. And it took 25 years to actually get a randomized controlled trial that validated the original recommendations for wearing condoms. And now it's an established fact, condoms do reduce the risk of acquisition of sexually transmitted infections as well as transmission of sexually transmitted infections. So I think masks will also provide these kinds of risk reductions. What will be difficult to determine is which mask is better than the other mask. And so then when you're looking at it from a system standpoint, at a hospital building with its inventory of masks, how many masks does it need and which kind? And can it use different masks? So the N95 is frequently cited as the better mask to have because it seems to provide a better protection. And it's actually even called a respirator because of the protection it provides. So it is better protection, but is it necessary? We don't have head-to-head trials comparing a surgical mask to an N95 mask.
Mm-hmm. All right. Intubating a patient, you have no idea whether they have COVID or not. PAPR versus N95.
So, I think
PAPR
with
plus
intubating the patient,
N95.
what's that?
I know you mentioned the last time we talked PAPR plus N95. So address
Right.
those options.
Right. So it's like, do you do an N95? Do you do PAPR? Do you PAPR plus N95? What if you don't have any time? Do you just put a PAPR on? I'm sorry, do you just put an N95 on and that's enough? We certainly know that protecting the mouth is helpful. Protecting the nose is helpful. And protecting the eyes is helpful. We also know that hand hygiene is essential. Head-to-head for all three of those don't exist. We also know that in the setting of intubation, for any infectious disease process, and probably the best studied of all of these will be tuberculosis, that if an individual presents to the emergency department with respiratory failure, has to get intubated, and they have pulmonary tuberculosis, that the risk of the intubator to acquire tuberculosis and actually then develop a positive test for TB is probably 4 to 8-fold greater if they're intubating, and then 2 to 3-fold greater for anybody in the room. Now, the virus is not tuberculosis, completely different organism. So, but they are finding that the most important predictor, once again, for a healthcare provider is if they intubated a patient without any PPE. But we don't know what level of PPE is the optimum one. And so that's kind of the problem. So the recommendations are confusing.
What about eye protection? If you go through the ER right now, you see a lot of variation from people just wearing glasses to people wearing like the mini glasses over your glasses to face shields to, goggles that seal to your face. Can you speak to degree of eye protection?
So I think any eye protection is better than none. I think enough studies have shown that just wearing your routine personal eyeglasses is not enough, and that something else needs to cover the eyes. And so whether it's a simple face shield that they have attached to some of the surgical masks, kind of like the ones that we'll use for influenza, the goggles really were well validated for sort of Ebola. And it's not clear if that provides extra benefit, although it may make the provider feel more confident.
Okay. And one more question. I feel like this is a whole talk tonight about PPE, but let's talk about aerosolizing, because currently in the recommendations, that's what creates a bright line for the CDC in terms of PPE level, and even for the WHO. So, and there's a lot of confusion about whether COVID is aerosolized. And I've even been getting asked questions like, oh, well, when you cough, doesn't a cough aerosolize stuff? Can you speak a little bit about these issues?
So we know that the actual SARS viruses, like SARS-CoV-2, when it causes its infection, the individual who's infected does cough. And we know that the cough is one of the main ways of transmitting the infection. We have not yet established exactly how much virus is transmitted, how many viral particles. We know that in general with the cough that, 6 feet of distance keeps you safe from the cough. So protecting you from the cough, reducing your exposure to the aerosolization definitely makes sense and definitely helps. But
does
then
a
all
cough,
the different ways to try and do it is what's hard.
Does a cough produce aerosols? My understanding is the difference between droplet and aerosol is size, and it's greater or less than 5 microns. Is that right?
Yes, they actually will get very particular on the size of the particles, and then the other thing they'll learn is that when they look at the different particles, sometimes the aggregation of particles can happen. So you won't have just one virus, but you can have an aggregate of virions around respiratory secretions, saliva, epithelial cells, etc. And then that can promote transmission and also some of this diminished transmission. And so we're in the middle of trying to figure all this out with the coronavirus.
Does a cough create aerosols in general? In your understanding of transmission, does coughing create an aerosol by definition?
As opposed to like a sneeze?
As opposed to a droplet. Like when we cough, do we generate things that stay around in the air and float for hours?
We do generate things that float in the air, not necessarily for hours. We know that different viruses are more infectious from respiratory specimens. So measles is probably 10 times more infectious than any coronavirus. And any kind of respiratory secretions from the patient can be infectious to everybody in the room. We do not think coronavirus is as infectious as measles.
We don't think it's naturally airborne.
We do not describe it as typically airborne. However, the epidemiology is really getting teased out. And whenever we talk about a virus, there's always multiple ways to define a virus and its ability to transmit. So one of the standard virus studies that are always done is called viral shedding. And you will actually measure the quantity of respiratory virus and how much respiratory virus is in, say, nasal samples, mouth samples, pharyngeal samples. This was very well characterized with metapneumovirus, which was a respiratory virus that really wasn't understood or even recognized until maybe 15 years ago. And I actually know some of my fellows that I worked with at the University of Washington. Their job was actually to measure all of these different viral quantities.
So we don't really know the answer to some of these questions, or a lot of these questions.
Which is really a fascinating thing, because when you talk to all the different real experts, like if you really try and pin down Dr. Tony Fauci at the National Institute for Allergy and Infectious Disease, that's the way he has to answer the question. I mean, got to be honest. Like, these are good questions. We don't know yet because we haven't been around long enough. We think these things, and I'm certain what will happen over the next few weeks is a lot of this is going to start getting teased out in different ways. And then we'll start understanding better ways to really maximize our PPE and minimize the risk of exposure to family members as well as healthcare workers.
Cool. Well, I think that's most of the questions I have for today's episode. Is there anything else you want to say to the BUMC ER and maybe the other Baylor ERs out there?
The amazing common sense thing cannot emphasize enough. Wash your hands. Wash your hands. Wash your hands. It has been shown washing your hands can be just as protective as all of these other methods. And so washing your hands after every interaction of any nature, even if it makes your hands dry, tough. Wash them.
All right. Thank you, Dr. Spock. This has been an awesome opportunity, and really appreciated you sharing your time with us.
My pleasure, Dr. Fine, and good luck down there in the trenches, and we'll have to do this again.
Yes, thank you.
All right. Have a good night.